Welcome to the deep dive. We've got a stack of your sources here covering updates and overviews on esophageal tumors. Our mission today is really to cut through the noise, pull out the most important nuggets of knowledge for you. This field, well, it's seen some major shifts in the last decade, and we're going to unpack what your material highlights as the key developments.
That's right. Your sources detail significant changes, in how we understand and manage both benign and malignant esophageal tumors, particularly the epithelial types and their precursors. A foundational update is the increased focus on precursor lesions, now often discussed, in their own right. It reflects a better grasp of their clinical significance.
Okay, let's dive into those precursor lesions first, because your sources make it pretty clear this is where a lot of the action is. We're talking mainly about Barrett dysplasia and squamous dysplasia. And there's been a really striking shift in treatment for one of these, hasn't there?
Absolutely. For Barrett esophagus with high-grade dysplasia, the sources highlight a major pivot away from invasive surgery and towards ablation techniques. This is a really significant change in clinical practice, offers a potentially less burdensome path for patients.
That sounds like a huge positive step, yeah. Reducing the need for major operations.
Yeah.
But I see your material also notes there's still quite a bit of debate around how best to treat low-grade dysplasia.
Precisely. And because of that ongoing uncertainty, in managing the low-grade disease, the two-tiered grading system, just low-grade versus high-grade, it remains clinically useful for now. It gives a clear distinction for guiding treatment, even as, the debate continues on the lower end.
Right. It seems we're also getting a more granular understanding of Barrett types, like intestinal versus foveolar dysplasia.
Yes, our pathological understanding is improving. But what's fascinating here, and a real challenge noted in your sources, is that despite this, accurately distinguishing these dysplastic changes from benign, non-cancerous regenerative lesions, it can still be quite tricky.
So it needs really careful pathology.
Exactly. Careful pathological assessment.
And trying to catch these changes early through surveillance, programs still faces hurdles, like the risk of missing spots, sampling error.
That's a persistent challenge, yeah. Though your sources do mention improvements. Techniques like brush sampling and cytology are aiding detection somewhat. Actually, this whole discussion around Barrett esophagus, it leads to a surprising point your material brings up. There's an ongoing, significant international controversy regarding its very definition.
Wait, the definition. The definition of Barrett esophagus is debated globally. How can something so, fundamental be up for discussion?
It really comes down to whether goblet cells are considered absolutely essential for diagnosis. In the USA, they generally are, but many countries in Asia and Europe, they don't consider their presence mandatory.
Wow.
So this fundamental difference, it can impact diagnosis depending on where you are in the world.
That's a critical detail. Okay, moving on then. The other precursor is squamous dysplasia. Your sources describe it as less common globally, maybe more seen where screening happens, but generally less well understood than Barrett's. Is that fair?
That's correct. Research is definitely still needed to fully understand its pathological and molecular features. However, on a positive note, there is growing international agreement on using a more reproducible two-tiered grading system for squamous dysplasia, similar to Barrett's.
Good. Consistency helps. Okay, let's shift to the malignant tumors, the two big ones, adenocarcinoma and squamous cell carcinoma. Your sources mention their incidence varies geographically, tied to environmental factors like diet, which is, fascinating.
It truly is. And a crucial update your material details for these cancers relates to staging, specifically changes in the TNM staging criteria for patients who haven't received neoadjuvant chemoradiation.
TNM. The system for classifying cancer spread.
Exactly.
And speaking of neoadjuvant therapy, that's treatment before surgery. That's become a much bigger part of management now, right?
Absolutely. It's really a cornerstone for many patients now. Your sources indicate that staging systems are evolving to incorporate the effects of this therapy on the tumor, reflecting its impact on patient outcomes. Also, for both types, there's a strong push in your sources for using a clear two-tiered grading system for how aggressive the tumor cells look, basically.
Okay. And I also noted that esophageal and esophagogastric junction, or OGJ, adenocarcinomas, they're increasingly discussed together in your material.
Yes, that reflects a practical convergence. It's based on shared characteristics. And importantly, the definition of an OGJ adenocarcinoma is now standardized, having its epicenter specifically within 2 centimeters of the junction itself, much clearer.
Good to have that defined. What about the latest treatment breakthroughs for these more common cancers, based on your sources?
Your material points to significant recent advances, yeah, particularly with immunotherapy and targeted therapies. A specific example highlighted is using ERBB2, or HER2, status. It's a predictive marker for guiding the use of anti-ERBB2 targeted therapy, particularly in OGJ adenocarcinoma.
Right, so treatment is getting more precise. Tailored.
Exactly. It shows how understanding the tumor's specific biology is directly impacting therapy choices.
Okay. Finally, your sources briefly touch on some less common or more complex tumors, mixed tumors, like adenosquamous and mucoepidermoid types. They sound like a bit of a puzzle.
They remain quite mysterious, according to your sources. They're rare, their definition and diagnostic criteria are often unclear, and, well, their origin is poorly understood. There's even debate if they are true distinct subtypes or arise differently, perhaps from gland ducts. It really highlights how much is still unknown.
So a significant area needing more research there. And undifferentiated carcinoma, quickly on that.
I guess your material clarifies that undifferentiated carcinoma is now recognized as its own distinct entity. It's no longer just lumped in as a subtype of squamous cell carcinoma.
Got it. And neuroendocrine neoplasms, NENs. Uncommon in the esophagus, but classified the same way as in the rest of the gut now.
Precisely. That standardizes how they're diagnosed and managed right across the GI tract. Makes things more consistent.
Okay, but let's try and wrap this up then. Based on the sources you provided, we've seen how the landscape for understanding and treating esophageal tumors, it's evolved considerably in just the last decade. From shifting towards less invasive options like ablation for certain precursors to refining how we stage malignant disease and developing these new targeted therapies.
What's fascinating here is the clear picture your sources paint. It's this blend, isn't it, of settled advancements like the move towards ablation for high-grade dysplasia and that push for two-tiered grading, sitting right alongside persistent controversies and significant unknowns, like that international debate on the Barrett definition or the complexities around those mixed tumors.
It really drives home how quickly medical knowledge is advancing, but also, the inherent complexity of these conditions and the ongoing need for more research.
And this raises an important question, I think, for you to consider based on the source material we've discussed. Given the rapid pace of change and these ongoing international controversies detailed in your sources, how might a patient's diagnostic journey or their treatment plan for the exact same esophageal condition, how might it potentially differ quite significantly depending solely on the geographic region where they happen to seek care?